Hello and welcome back. We are continuing on with our discussion of AV heart blocks. And now we are going to get into the final type of AV heart block, which is a third degree. This is also called a complete AV or complete heart block. This is the worst type of block that you can have. It is complete blockage, right? When I say blockage, what I'm talking about is the blockage within the electrical conduction system from the SA to the AV down into the bundle of His, into the Purkinje fibers, right? So this, again, complete blockage, not a good thing. So the first thing right off the bat, when you're looking at your strip, what's the first thing that we notice? Well, I'd say that it looks a little odd, a little bizarre, right? It looks like the P waves are doing their own thing, and the R waves are doing their own thing. And you can see it's pretty consistent throughout, but they're not consistent with each other, right? So for every QRS complex, you should have a P that is glued to it. So P, QRS, P, QRS, P, QRS. Now look, P, QRS, there's your T, P, no QRS, right? Also no P. And this P kind of is like getting engulfed here in this T wave, if you can kind of make that out. So again, P waves are doing their own thing, and the QRSs are doing their own thing, right? So they're going at different rates. They're firing at different rates, which is really not good, okay? And you're gonna expect to have more P waves because they are paced by the SA node, right? But you're gonna have less QRSs because they're paced below the SA node into the AV junction. And that's where our problem is, right? Our problem isn't with the SA node here. It's not a conduction problem with SA. It's an AV block, not an SA problem, an AV problem. So that's why we see more Ps, and that makes sense, right? So again, yes, the rate is regular, might appear regular due to the P waves that end up getting hidden in those QRS complexes, right? But everything here is uniform. Now it's just that the SA and the AV are firing differently. So we have a ventricular rate, right, of 20 to 60, which is our QRSs, and we have an atrial rate of 60 to 100, which is our P waves here. So again, P waves normal, but there's no connection with the QRS complex. Again, they're not married to the complexes. That's a really bad thing. Causes an inconsistent relationship. So this complete blockage occurs at the AV junction, common bundle, or the bilateral bundle branches, right? Anywhere along in there, this can occur, okay? We do have, now this is a little deep in the woods, you won't really have to know this for NCLEX, but just for your, the sake of your curiosity, we do have, within the heart, we do have another pacemaker that's distal to the block that takes over in order to activate the ventricles. And the reason being for that is because if we didn't have that, the ventricles would just completely stop. It'd be a standstill. So here's some different causes, right? It could be, severe heart disease, coronary artery disease, someone who's had a acute coronary syndrome, right? Myocarditis, acute infection, scleroderma. And these are some different drugs that can potentially cause this. Digoxin, right? Beta blockers, calcium channel blockers, right? These are all working on the cardiac tissue here. And so, just be wary if you have a patient that presents in your ER and you're doing your assessment, you ask on medications, be wary of these, especially DIG. DIG can be pretty potent. So the treatment for a third degree AV block, we need some sort of temporary pacing, right, until we can get a permanent pacemaker placed. So, commonly, you can use a transcutaneous pacer before the, implementation of the permanent pacemaker. It just depends. We can also give epinephrine. We can give dopamine, right? And this would be for acute symptomatic episodes. Patients, complaining of chest pain or, oh, I just got this funny feeling